Great. So thank you all for attending the Dunlevie monthly lecture series. Just a few updates with the SMFM coming in San Francisco here shortly. We did very nicely this year with 2 oral presentations and 15 poster presentations and a roundtable, and we'll be canceling next month's lecture series because of the conference. And next slide. And in March, Dr. Vincenzo Berghella will be lecturing to us on cesarean section and various techniques and considerations around cesarean section. But today, I have the unique pleasure of introducing a dear friend and colleague, Dr. Alison Cahill. Just say a little bit about her because I could probably go on for the whole rest of the time telling you about Alison, but she received her BA Art History, summa cum laude, and college honors from Yale University, went on to a medical degree at the University of Connecticut School of Medicine, and a Master's of Science in Clinical Investigation, following that at Washington University School of Medicine in St. Louis. She did her residency at the University of Pennsylvania Medical Center and her fellowship in maternal fetal medicine at Washington University School of Medicine. She is the director of Health Transformation Research Institute at Dell Medical School at the University of Texas at Austin, and professor with tenure. If you can please mute if you're not speaking, please. Professor with tenure in the Department of Women's Health, Dell Medical School, University of Texas. Prior to that, she was chief of the Division of Maternal Fetal Medicine at the Washington University School of Medicine. I'll say that Dr. Cahill is truly one of the leading international figures in our field, with a list of accomplishments that will take quite a long time to enumerate. Her interests are neonatal and maternal outcome research with 3 main areas of focus: reducing term labor and delivery related morbidities by optimizing labor management, and understanding physiologic and pathophysiologic labor, intrapartum fetal monitoring, and the impact of obesity on pregnancy outcomes. She has experience in multidisciplinary collaboration, as well as design, conduct, and publication of clinical studies with over 250 peer-reviewed publications. Dr. Cahill has mentored dozens of investigators, and over 2/3 of the fellows and junior faculty she has primarily mentored have pursued academic careers, and several are independently funded investigators. She is chair of the Committee on Obstetric Clinical Consensus, formerly Obstetric Practice, for the American College of Obstetrics and Gynecology. She also serves as the editor-in-chief of the American Journal of Obstetrics and Gynecology Global Reports, and is the senior editor for the Society of Maternal Fetal Medicine editions of the American Journal of Obstetrics and Gynecology. We are so fortunate to have her here today to talk to us on evidence-based management of the second stage. Please join me in welcoming Dr. Cahill. Alison, the floor is yours, my friend.
Yeah, sir, my friend. Thank you so much. It's great to be with all of you. Great to see these familiar faces, and thank you so much. And congratulations to your group on such great accomplishments for this year's SMFM. So I'm going to endeavor to share my screen. We don't have a super ton of time together, so I am going to try to see if this works. So can somebody give me a thumbs up if you have your video on, that you can see my, okay, good.
Looks great. Thank you.
And I'm in the good. I'm in the mode that makes sense to you guys. Perfect. So thank you so much for inviting me to talk to this prestigious group. You guys have a group that all of us from around the country and really internationally look up to in terms of the work that you guys are doing. So it's really a privilege to be here. I wanted to talk a little bit about the second stage of labor today. And then hopefully we'll have a little bit of time for discussions to follow. I sadly don't have any financial disclosures, but if you guys can think of any for me, just throw them in the chat, and it's a lifelong endeavor there. So a couple things just to level set. So in terms of the second stage of labor, and this may seem like sort of the most basic thing, but in fact, it gets a little bit confused, particularly in the more historic literature in terms of what we're talking about. So from a definition perspective, right, we're talking about, and probably our students and residents would tell us sort of it's absolutely starting with complete cervical dilation and then finishing with delivery of the baby. So that's kind of that is actually the physiologic second stage. And then what we do in that time period is kind of in a way up to us. And so management of the second stage. So what we do during that period is really what we'll be talking about today, and specifically talking about delayed pushing or otherwise thought about as laboring down. And this is really an issue for obstetric practice in modern times because of epidurals, which, you know, our anesthesia colleagues are amazing to have this sort of offering to patients who choose to have regional anesthesia, but are still able to effectively deliver their babies. But as all of us know, are there obstetricians who deliver babies in the audience? I think, yes, there's some nodding. So yes, so right, so we know that patients who don't have anesthesia, we really, for the most part, as a general rule, we don't coach them when and kind of even necessarily how to push, because they do that instinctively. But we a little bit take that away when we have regional anesthesia that's positive for all of the other reasons that we think about. So that's really the sort of framework with which we're thinking about this. And I know you guys, all of us sort of regionally have a different patient populations and preferences that we take care of. But I'll say that here at my current institution, at my prior institution, the uptake of epidural anesthesia is probably about 85%. And the national rate is quite high. And I don't know, Yasser, do you guys have a?
Yeah, it's about that. So I think the last I saw was 82%.
Yeah, great. So I'm not so crazy. So not the crazy kid from Austin so much today. So basically, you know, this is a common thing that we face and trying to figure out what to do. So I like to add, you know, when I'm talking to groups, this great Dunlevie experience for me. And there's, you know, so much emphasis on all the things that you guys are after, including investigation, like to kind of talk about the origin of some of these questions, because sometimes I feel like, especially for junior people, like, how did you think of this or whatever? And for me, this was super organic. So essentially I did my, as Yasser said, I did my residency at Penn. And I was taught that when you're complete, you push. So that was just it. I mean, when your patient's complete, you find them to be complete, they push. So that was the end of the story. So I didn't have much questions about that. And then I went off to my fellowship at WashU in St. Louis, and I went to board sign out, and I had all these patients that were complete. And I was getting this in board sign out, and nothing's happening, right? So you look at like the toco, and you're used to seeing like this, right, thing that you know that they're pushing, and nothing's going on. And I'm going, what is going on? So what's the lady in 204 doing? Oh, she's laboring down. And I'm like, all right, what are we doing there? Well, she didn't look like a good pusher, or, we were going to try and, increase the chance that she's going to have a vaginal delivery, or we were going to do all these sorts of things. I'm like, all right, how long has she been laboring down for? Well, we're not sure. So anyway, I sort of absorbed all of this, and I felt like, gosh, hang on a second. I'm being trained by all these terrific people, both sides, and this can't be true, right? So what is actually the truth? What's out there, and how do people feel so passionately about this issue? So I dug into the literature to see what there was, and this is what I found. So I'm going to walk through a handful of studies for you that were sort of the backdrop to my thinking about this. And they're all set up the same way. So the first is going to describe what the study looked like, and the next is going to describe the outcomes. So the first of these was the Hansen study, and this is the only one that I'm going to show you because it enrolled nullips and multips. So that was sort of unusual. And I'll show you at the very, very end, and hold me to my word about this, but you'll see that this is really shouldn't be an issue for multips because their second stage should be actually quite short. But in this case, they enrolled nullips and multips, term regional anesthesia, like we talked about. That's actually how this issue comes to be a question. Induced or spontaneous labor, so that makes sense. 312 patients randomized, only 252 analyzed. That's a bit of a bummer. I'm not sure how you lose 60 patients on your labor and delivery floor, but I'm sure it was sort of an honest thing. Any which way, they were randomized to delay for 2 hours for nullips or 1 hour for multips or immediate pushing. And they had this caveat, head at the introitus, and also very interestingly, and now you're going to see this as a theme, they were evaluated every 30 minutes. So right away for me, this idea that everybody is laboring down, it's good for everybody. There's not really an indication for it per se. And we don't know how long they were laboring down, but it'll come to us when they should push or what have you, was not actually how the trials were conducted. And you'll see kind of what that looks like. And so what did they find? They found that if you delay pushing, you have a longer second stage. It's kind of pretty intuitive, right? But you had a reduced timed actual pushing. Reduced fatigue was reported in nullips, and then no difference in these things, pH, APGARs, other types of measures of injury. So then we had this study by Beth Plunkett, who looked at nullips, regional anesthesia, again, induced or spontaneous, 200 patients plus randomized. Again, this was a little bit different, 90 minutes delayed, same sort of situation. They were evaluated every 30 minutes to figure out whether or not we should abandon the arm that they're in versus immediate pushing. And what did they find? Again, they saw a longer second stage. Again, no difference in time spent pushing, cesarean, spontaneous vaginal delivery, pH, fever, hemorrhage. And then we had a trial by Gillespie that was, again, nullips, same situation, greater than or equal to 36 weeks, induced or spontaneous, super helpful because all of that applies to us. They excluded women that were over 275 pounds. No idea about why that was. 77 patients randomized. Delay was 120 minutes. And they, again, were evaluated every 30 minutes compared to immediate pushing. And here's an example of kind of what they saw. And this is not surprising. So delay is the first column, and then immediate is the next column. P is on your right to give you a sense. And so length of time pushing was longer with immediate pushing. Length of the second stage, which is the second row, was quite a bit longer if you delayed. But then really no difference in other types of things that folks wanted to focus on. And then we had a trial by Fitzpatrick. So again, nullips, term, regional anesthesia, induced or spontaneous, 178 patients randomized. Delay was 60 minutes compared to immediate. This was a little bit tough to kind of consume, I would say, on our side of the pond, just because pushing for all groups, regardless of how you were randomized, was limited to 60 minutes. So this was the local standard. And if you didn't do something by then you got forceps. Or if you weren't a candidate for forceps, then you got a section. So that was a little bit different. Although I'm sure residents and fellows in the audience would feel like that sounds awesome. So a boatload of forceps there for that group. And again, same thing, longer second stage, but no difference in all of these things that we have listed there. And I think that it's important to sort of remember that you saw the size of those trials, right? So they were relatively modest, and they weren't large enough to look at that thing that kept on being reported. Like there's no difference in maternal morbidity. There's no difference in neonatal morbidity. That's kind of tough to say in term kids when you have, 100 patients in your study, because it's probably not quite big enough. So then this was sort of the penultimate study at the time. So this was a study by Fraser and his colleagues, Bill Fraser, and this was the People trial. His name might seem familiar to some of you. Bill Fraser was the architect of the trial for amnioinfusion for meconium. I age myself, but some of you might not realize that we used to actually do an amnio infusion to sort of with this idea that we would like wash out the meconium badness and actually improve neonatal outcomes and reduce the risk of meconium aspiration. And of course, that was ridiculous and didn't work. And he did the sort of multi-center trial to prove that that's not the case. So in fact, here he performed another multi-center trial again in Canada, looking at NULIPs, term, regional anesthesia, induced or spontaneous delivery. And this was a pretty large trial. So this sort of really followed up on those groups of studies that we just reviewed with a much larger sample size to try and get after some of these remaining questions. Should we have patients, especially NULIPs with regional anesthesia, should they do this thing? Should they labor down? Should they delay pushing? Or should they actually push when they become complete? And so in this study, the delay was quite significant. It was 1 hour and 20 minutes, which only one prior study that I showed you actually chose a time that was that long. Or a patient had irresistible urge to push, or the head was at the introitus. And like we kind of talked about, similar to those prior trials, there was some evaluation of the patient ongoing. So they weren't just sort of the answer that I got at board sign out, like, oh, I don't know how long she's been laboring down, but looks good or whatever. But actually there was protocolized how often they were checked. And in this case, they were checked fairly frequently. So every 15 minutes. And the idea here is that, well, if you're going to have a patient labor down, the physiologic concept is that the uterus is doing all the work for these explosive efforts. So there should be descent and progress happening. And if you don't evaluate that, then kind of what are we doing during that time? And that was compared to immediate pushing, of course. And so what did they find? So they found a decrease in difficult delivery, and we'll talk about that in a minute, an increase in maternal fever, and an increase in low baby pH related to delayed pushing. So this was the first study that was big enough to potentially kind of look at some of those morbidity factors, but there was this important decrease in difficult delivery. So again, we'll circle back to that. And then no difference in spontaneous vaginal delivery, cesarean, or patient satisfaction. And that was also a big thing. There was this big discussion that patients prefer X or Y. And so it was a great thing that I feel like, in a way, Bill and some of his contemporaries were ahead of the curve because they were really assessing patient experience during some of the trials that they were conducting. And that was important. And it's been an important influence on me. I mean, I think we kind of know that now. We think about those things a little bit more frequently. But I think those guys were a little bit ahead of the curve in terms of thinking about how patients feel about their experience. Okay, so let's dig into it a little bit here. So delay is on the left and immediate is on the right. And then on the far right, we have relative risk and 95% confidence interval. So we talked about the reason that this was considered a positive study, meaning it showed evidence for benefit of delayed pushing, was because of this thing, difficult delivery. And you can see that that was statistically significantly reduced in the delayed group. So what, in fact, is a difficult delivery? So really, it's the 3 rows that's below this. So it's anything that's not a spontaneous vaginal delivery as they define it in their study. And it was completely driven by this row right here, mid-pelvic procedures. And so again, you remember, I'm still sort of a lowly fellow trying to soak in everything that everybody's teaching me. And I'm thinking, okay, so we have all these studies that show a longer second stage, not so much with any evidence for benefit. I'm not sure, maybe nothing bad. They're all small. I don't know. And then we have this trial, which really the driver of the positive findings are these mid-pelvic procedures. So that's what drove that composite. And mid-pelvic procedures are rotational forceps. So I guess we have a lot of people off video, but does anybody, yes, or what's the sort of uptake of rotational forceps at your place?
It is just about 0.
Yeah. Thank you. So that's actually, so I was trained in my residency in rotational forceps. But really, it very quickly, I mean, it was falling out of practice and no one that was around me, did those things anymore. And there's, that's a different talk altogether. But let's just say it's not really part of modern practice. So this trial was hugely important because it was big and it showed us some things, but the real positive driver of why you would delay pushing, according to the Fraser trial, would be to reduce mid-pelvic procedures. And then suddenly we found ourselves, you can see this is published in 2000. Can you guys see my pointer? Great. You can see this is published in 2000, right? So I'm thinking, well, gosh, we don't do any of that stuff anymore. So this is sort of strange. We're in this spot where like quoting this literature, it's like not powered to look at what we care about or, actually, we don't do this stuff anymore. So we were kind of examining some of this evidence and saying, okay, so I was sort of being a little bit flip talking about that one trial that lost 60 people on labor and delivery. But just to say that the science that we perform in OBGYN has really evolved itself, I think, to really executing high quality studies that change our practice. And you guys are a perfect example of that. I feel like Yasser and your team, have really kind of led the way to say, well, actually, we can do an RCT on that. We can actually tackle that in a careful and thoughtful way. And we can actually move the needle in terms of how we practice. But when we looked at this literature, we said, I don't know. Yes, people have come behind and done meta-analysis and jumbled this all together, but some of these studies are studies that, we probably wouldn't think would change practice in current times. So we thought about approaching a meta-analysis in a little bit a different way, and Method Tooley led this. And so the question was, as many of you who do meta-analyses know, you can sort of a priori decide what your approach is going to be. And you can say, okay, I'm going to set this up because I'm going to stratify by, randomized studies or not, or studies that included X or not. But you can use other things. And so there are metrics to help determine things that you include based on quality. And that's the study that we said. We wondered whether or not these sort of meta-analyses that sum things up of these very small trials plus Fraser were potentially skewed by quality. And so here's an example of what we saw. So this is like a little bit busy, but this is the outcome here is spontaneous vaginal delivery. And if you go all the way to the bottom, we sort of said here, okay, so anything heading to the right here is favoring delayed pushing. And anything headed this way is favoring immediate pushing. And then you can see that here are all the studies, high quality up here, lower quality down here. And this is the overall. So let's start with overall. So we started from the place where prior meta-analyses have said, okay, we'll put everything together. So we put everything together with no other weighting than the usual weighting based on ends and so forth and variance. And you can see that we had a statistically significant relative risk favoring delayed pushing. So that this diamond not touching unity tells us that there's an increased chance of spontaneous vaginal delivery if you delay pushing overall, if we sum it all together. But then we go and we look at the high quality studies and the low quality studies. So let's start down here. So the lower quality studies, which were smaller and we worried about some analytics and so forth, and we scored them on a sort of a traditional, like accepted rubric. And you can see that here we had a statistically significant difference favoring delayed pushing to increase the chance of spontaneous vaginal delivery. But now we're going to hop up here. And here's the high quality studies all summed up together. And now you can see that this diamond touches unity and that this is no longer statistically significant with a confidence interval that crosses unity. And so
looks like Ann Waldrop.
we really felt like, well, gosh, the findings overall of these meta-analyses were really driven by lower quality studies. And that these higher quality studies were really showing us that we hadn't really found the answer to the question that we wanted to know clinically. So we saw in all of these studies that delayed pushing is definitely associated with an increased chance of a longer second stage. And briefly, I'm just going to answer this question. Do we care about a longer second stage? I'm going to tell you, yes, we do. And here we go. I'm just going to show you a few things. So this was a study by Rouse. It was a retrospective cohort study, a secondary analysis of the Fox trial. That was the Pulsox trial that was negative. And so they looked at each hour of increasing duration of the second stage and maternal and neonatal outcomes. And what did they find? So they found maternal wise, for each hour increasing, there was an increased risk of choreo, third and fourth degree lax, at-knee, NICU admission. So Camille Leray performed this secondary analysis, and this was a secondary analysis of the People trial that we just talked about from Bill Fraser. And this is sort of a large study, as you recall, and looked at it the same way, increasing hour of the second stage after the first, maternal and neonatal outcomes, increased risk of choreo, hemorrhage, cesarean, neonatal, lower pH. And then Allen's study looking at a population-based study, and this time set up things a little bit differently. So those classic sort of reference where duration of the second stage becomes abnormal, if you will, after 3 hours in null-lips with an anesthesia and multips after 2 hours. And again, saw maternal increase of choreo, trauma, hemorrhage, neonatal, NICU, low APGAR, low pH. And Laughlin similarly prolonged versus within, and that was the same, those traditional parameters, and saw the same increased risks for maternal and neonatal outcomes. So these longer second stages associated with risk. And then Bill looked at this from the perspective of length of the second stage, and actually specifically length of pushing in nullips and multips, and showed increased risks as well, both in cesarean and neonatal morbidity. And so if we take all of that together, we felt like delayed pushing may or may not shorten pushing duration for nullips, but it clearly prolonged the second stage that was seen again and again. It didn't seem to be associated with improved outcomes or worse outcomes. But if we look at it in the context of prolonging the second stage, so your clock starts when you become complete, then certainly the longer we go, the worse the maternal outcomes and the neonatal outcomes. And we're talking about risk here, right? So we don't know that for sure. We wish we had a crystal ball. We wish we knew who was going to deliver spontaneously, but we just don't. So that led us to this. So we propose to look in modern practice in the United States, regionally representative, to look at immediate versus delayed pushing in nullips who have neuraxial analgesia. and look at whether or not it improves spontaneous vaginal delivery to deliver right away. And we hypothesized that because we said, well, if they don't have a regional anesthetic, we don't teach them to push, and people know instinctively to push right away. And sort of maybe that's showing us that's what to look at. But we were powered to look at maternal and neonatal morbidities, and also performed a 3-year follow-up study to look at the pelvic floor. So for this study, we screened over 12,000 nulliparous women. They all had regional anesthesia. Over 2,400 were randomized at complete dilation, and either they were randomized to push immediately or to delay pushing for 60 minutes. And as I said, our primary outcome was spontaneous vaginal delivery. This is the top of our figure 1. And as you can see on the right, the primary reason women were excluded is that they didn't meet inclusion criteria. And the secondary reason was that they declined to participate, with 2414 randomized, and we followed the intention to treat principle. So the trial was stopped early. And why would that be? So this is always like a super hard thing for an investigator. So it was stopped early for 2 reasons. The first was futility. So right here, the primary outcome, as I said, was spontaneous vaginal delivery, and we'll scoot over here. And this is the relative risk between the 2 groups. So you can see, I think that the DSMB told us that we probably could continue on until I was like retired and never show a difference in spontaneous vaginal delivery. So our hypothesis was incorrect, that immediate pushing would improve spontaneous vaginal delivery rate. But in fact, sort of neither strategy did. But it was also stopped early for harm, or concern for harm. And the 2 reasons were this: an increase in postpartum hemorrhage that was seen in the delayed group right here, and an increase in the risk of infection, chorioamnionitis. And on the neonatal front, there was an increase with delayed pushing in abnormal cord gas, or confirmed or suspected sepsis. And so they felt it was important to stop the study for both futility and for harm. So we came away from this and said, well, we've been humbled. Delayed or immediate pushing does not increase the risk of spontaneous vaginal delivery, but delayed pushing is associated with increase in postpartum hemorrhage, chorio, neonatal acidemia, and neonatal sepsis or suspected sepsis. And I'll just leave you with a couple of last thoughts. Hopefully we'll have time for kind of questions and comments. But so many of you are likely familiar with this document that I feel like I've gotten hate mail over from time to time. But anyway, the intent here was that there was a thinking that there was a rising rate of cesarean, and we didn't have a consciousness about why that was happening and what we could do about that. And ACOG was, which Yasser was intimately always involved with, very interested in sort of creating a document that would address that. And so very specifically in the document, it says that a specific maximum length of the second stage has not actually been identified. And it also says allowing for the historical amount of time for pushing with an epidural for nullips and multips is reasonable, and that longer durations could be appropriate on an individual basis. And I think that the kind of quoting of this document has a little bit gotten away from us, because in the text itself, not in the box. So the box says this, exactly that thing. But in the text, it says, it's been identified in some normative data, including Zhang, that the second stage might be sort of normally longer, but there wasn't outcome data or any other types of things. And I think it's been taken out of context, that we should sort of let these second stages go kind of on and into perpetuity. And so I just wanted to show you kind of 2 last things. So this is from Zhang and Safe Labor. And remember, we're talking about the second stage. So we're going to skip right down to the bottom of this messiness. And we're going to look at this row right here. So second stage with epidural anesthesia. And so here, right over here, is with the 95% confidence interval. So this is the reason this was published right before that safe prevention of the first cesarean was published. And the thinking was, wow, that's a little bit longer than we thought letting people have. Maybe we should let them have longer. But I want to focus on this. So I want to focus on this 1.1 hours and 0.4. So this is the central tendency for a patient that's a no-lip or a patient that's a multip to deliver. So that means 50% of your patients with epidural anesthesia should deliver within 1 hour and a few minutes, no-lips, normally, and multips in less than half an hour. And so sometimes we think about these outer limits, and sort of like, have we let them have enough time, et cetera, but like, let's kind of focus on what we should expect. And this is what we actually should be expecting from patients in terms of their kind of how they're going to do in the second stage. And this is the last thing that I wanted to show you, which is this is from our group looking at normal labor data, and we're looking at station by cervical dilation. And here, busy table, but let's skip right down to the heart of the matter because we're talking about the second stage. So here's everybody complete, no-lips on the left, multips on the right, and you can see this is station. So station is on average +2 for no-lips and multips when they become complete. So like when you have a resident come back and are like, oh, she's complete, but I think she's 0 station, that's not right. That is, or higher than that, that's sort of a very abnormal, good to flag labor curve that's, likely not maybe going to go terrific. Anyway, there's tons of questions left as it relates to the second stage. So many, some are, how pushing happens, should it be coached or not coached? How many of us were taught to sort of like, okay, you're going to take a deep breath in and then you're going to count, we're going to count to 10, you're going to push, and then we're going to do that 3 times or whatever, that's like all made up. Oxytocin use and dosing in the second stage, right? How many of us just like run it, keep on going? If you're on it, you just keep on getting whatever. And if you're not, you don't. And we didn't even know if that's effective. Position. And then I think the holy grail question is, how long is too long? I think we just don't know, but I think we have a growing body of evidence to make us a little bit careful about how long we let patients' second stages go. Anyway, I'll wrap it up there. Thank you guys so much for having me, and happy to take your questions or comments or throw whatever you want to throw at me through Zoom.
Alison, thank you so much. This was great and a wonderful review of the literature. I will open things up for questions. I have a few of my own, but I will hold off and see if anyone in the audience has questions that they. Yeah, here.
Alison, that was great as always a pleasure to hear your insights and expertise. I was just curious, in your trial, how did you what were the recommendations in the 2 arms about somebody that was in either group and descent did not occur? Like, let's say after an hour, what was the recommendation, the clinical recommendation, and how do you spoke about it a little bit at the end, but I know it's for lack of time, but what's your thoughts on lack of descent in the construct of delayed versus not, and also like the amount of time that we quote unquote allow women to push nowadays?
Yeah, thanks, Jared. It's great to see you. We didn't talk about that, and it was a pragmatic trial, so we didn't specify that. So the only thing that was sort of really live at the time was that safe prevention of the first cesarean, which actually has a caveat. I went quickly through that slide at the end, but it says, assuming, descent is happening. The data for this are pretty light, but older recommendations would say that if patients are pushing adequately and don't make descent in the first hour, then it's reasonable to call that a rest. I personally agree with that. I don't think that we as a group, my place especially, we don't assess patients frequently enough during the second stage in terms of their progress and how they're pushing in a kind of an active management type of way, an active management of the second stage. But I think if patients are pushing adequately by your best judgment and they don't make any dissent in the second stage, then I think that that's fair to call it a rest. I think that one thing, it at least is always in my mind, is that, you know, there's this sort of idea that we're trying to prevent sort of unnecessary cesareans, if you will. And that is rarely a second stage cesarean. So if you saw those numbers, you know, the rates of spontaneous vaginal delivery in NOLIPs was in the high 80%. So most women who make it to complete are actually going to achieve a vaginal delivery of some type. And I think that we probably, I think that it's easy to fall into this sort of like, let patients have their 3 hours. I think that that is sort of doesn't make a ton of sense to me personally, because if they're showing you that they're not going to make any dissent, then they're actually not going to make any dissent for the next 2 hours, but they certainly are going to increase the risk of hemorrhage and a variety of other things. But anyway, my 2 cents.
Thank you.
Alison, thank you for that. We've got a question in the text from Dr. Mark Body in our Salinas practice. Yes, what are your thoughts about the protocols that have suggested the number of contractions is a more pertinent measure instead of duration of the second stage?
Yeah, thanks for that question. That's really interesting. I think that, and I think that it's just really understudied, to be frank with you. I think that, and there's this very intimate or close interaction between contraction number and how fetal heart rate tracings look and evolve over the course of the second stage. And so I think that there's an important piece there, but I think that it's a great question. I think that generally there's this sort of nice push in the literature to sort of ask, well, should we not be using sort of some centile, 90th, 95th, 97th, whatever it is, of a normative or abnormal threshold, which I, of course, just did. But to actually look at them in terms of what threshold of length is associated with morbidity and actually consider those sort of lengths. But that's, again, back to length of the second stage and not, to your point, number of contractions. And of course, we have a very hard time measuring strength of contractions and other types of things during the second stage because of just the nature of the beast. So it's a great question. I think it's just understudied, but hopefully you'll study it.
I have a question, Alison, and that is, you know, you've looked at delayed versus immediate, but are there any studies planned ongoing that actually looks at this issue of length of second stage beyond the delayed immediate? I mean, let's say everyone pushing immediate. Are there any plans for large randomized trials looking at outcomes with that?
Yeah, I'm not aware of any that are registered or any that are necessarily planned. I do know that, you know, it's a rich, well, fairly rich data set. It's not gigantic, but a fairly rich data set from the trial. And there is sort of an incremental look at lengthening the second stage within the trial, just because it was negative between the two groups, that's being presented this year at SMFM. So I think we're beginning to dig into some of that data, but it's very difficult, you know, of course, as you know, if it's not an RCT, then it's really a little bit confounded by indication. So we're really trying to kind of see what we can make of the data that we have, but I think that it's really tough. I think that we have really good observational data to say that these really long second stages have really high risk with diminishing reward in terms of spontaneous vaginal delivery. But in terms of kind of patient selection to that and so many patient covariates, I think it's really a challenge, and it's sort of understudied in my opinion.
And at 2 a.m, after your resident has allowed for an 8-hour second stage, what are your favorite approaches as you head to the operating room?
I actually run to the parking lot screaming. No, I mean, I think that I think that in terms of risk of hemorrhage and extension and all the things that we know, they're incredibly high. And oftentimes you found yourself in that situation because, you know, there are other factors that you couldn't anticipate. The baby is unanticipatedly much larger than you expect, or whatever else it might be. So I think, you know, having anesthesia prepared for what could be a fairly significant hemorrhage, I would say, other than, you know, other than PAS, I think second stage cesareans have probably been the most life-threatening hemorrhages in my career that I've been involved in. Maybe a rupture, but you know, they're right up there. So I think being prepared for that, and we do other small things, which I'm sure you guys do too. Like, you know, it might be a primip, and so kind of technically an intern's case or whatever it might be, but it can be the intern's case until they kind of open the uterus, but then the delivery is going to be by somebody more experienced. And then being, you know, prepared to have a vaginal hand or whatever that might be. And I don't know if you guys are experiencing the nursing crisis that we're experiencing, but it's remarkable how many people are in the room that actually have like never heard of that and don't know that. So I think there's no shortage of things you can talk through before you go in, as you guys all know well, you know, to sort of raise those things, because I think having somebody have no clue what you're asking for when you're kind of in duress and been in, you know, sort of a few minutes in trying to deliver the kiddo is tough.
Alison, thank you so much. This is such an important topic, and one that has bedeviled obstetrics and continues to bedevil obstetrics. And so thank you for all your work, past, current, and future in this area. If there are no more questions in the chat or among the audience, I think we can conclude the meeting. And Happy New Year, everyone. And looking forward to more meetings and to seeing folks at SMFM, and looking forward to seeing you, Alison, here in a few weeks.
Thank you guys so much for having me. See
Thank you.